My pleasure to be talking to the group at ICANN Mount Sinai this evening, our time. As has already been said, the Hazelwood study was led by me and colleagues at Monash, but in fact was a collaboration, and I need to acknowledge the participation of the Alfred Hospital, Federation University, University of Adelaide, University of Tasmania, and our Commonwealth Scientific and Industrial Research Organisation. These are my disclosures. So it will soon be Passover, and should I feel like Moses on Mount Sinai when the Lord says, "Take 2 tablets, call me in the morning," well, I'm not going to be talking to you about the Ten Commandments. I would like to share our experience, and I'd be interested to hear your experiences. I was asked to set some objectives, so my hope is that by the time we've completed this session, you'll be able to give examples of the effects of landscape fire smoke on respiratory symptoms and lung function, and appreciate some of the psychological and other effects of landscape fire smoke. The outline for the presentation is that I'll tell you a little about the Hazelwood coal mine fire, a big picture overview of what we've found, what still remains to be done, and I'm going to address some specific respiratory questions since that's a major interest of mine, and I think also for many of you. And this is some of our recent, as yet unpublished work. Do respiratory symptoms persist? What were the impacts on lung function? And what were the psychological impacts? And finally, I'll pose a question to you. What do you think should now be done after the wildfires around Los Angeles? I've borrowed this cartoon from the Hamilton Spectator, and it sets this particular problem in the context of climate change. So as you all know, climate change is resulting in more extreme weather, extreme floods, collapse of biodiversity, but as one of the horsemen of the climate crisis says, it's extreme heat that's just killing it. And that, of course, comes with drought and wildfires. The Hazelwood coal mine fire was ignited by embers from a bushfire which got into the mine at a place called Hearns Oak, a section that was thought to have been worked out, but there was still plenty of coal to burn. And you can see in these pictures, which I've taken from Keith Pakenham, at night it looked like a scene out of Dante's Inferno, and during the day the smoke was spreading up and down the Latrobe Valley. Now, this is a rather busy slide, but I show it to give you some extent, some idea of the concentrations that residents were exposed to. At the main pollution metric is one that will be fairly familiar to you, fine particulate, PM2.5. And you can see on the first day of the fire, CSIRO estimated that it reached 3,750 micrograms per cubic metre. Now, this is a little complex, but this purple line shows the direction of the wind. And basically, the wind changed on the second day. And I think that's one of the reasons that the effects were not more severe and there were not more deaths. It took a little while to get monitoring equipment near the fire, so that once dust tracked machines were moved in, you can see that the model agreed quite well with actual observations, and later a TOM, tapered element oscillating microbalance, was moved in by our EPA, and again there's quite good agreement with the model predictions of PM2.5 concentrations. And the fire went on for 6 weeks before it was finally extinguished. So, big picture overview. The health department was petitioned by the local community to sponsor a health study. And after community consultation, the tenderers were asked to address 10 questions. And this, in fact, was the first successful tender that I had ever led. And these were some of the questions. So, is there evidence that people in general and susceptible subpopulations in particular who are exposed to emissions from the Hazelwood fire compared to otherwise similar people who are not exposed currently have clinical or subclinical cardiovascular or respiratory conditions that could be associated with clinically important adverse health consequences in the future? And we've largely answered that question. We didn't find much of an effect on cardiovascular conditions, apart from a small increase in medication. We did find that exposure was associated with cough, poorer asthma control, some features of chronic obstructive pulmonary disease, and stiffer lungs on mechanics testing by forced oscillation. I'm going to talk more about some of our recent findings shortly. The community was very interested in whether there was any difference in birth weight of babies born to mothers exposed to emissions from the fire. And overall, there wasn't. However, mothers who had gestational diabetes, and gestational diabetes was more common in the exposed women. The mothers with gestational diabetes had babies that were 97 grams heavier for every 10 microgram per cubic meter PM2.5 exposure. Is there evidence that people in general and susceptible subpopulations in particular, including children who are exposed to emissions compared to those who are not, have a higher prevalence of psychological distress? And we answered that question with an adult survey and school study, and we found that for the adults, the impact of event scale revised and Kessler's 10-item general distress scores were related to PM2.5. In the children, we found that the total score on the child revised impact of event scale was higher in Morwell than schools elsewhere. What socio-demographic factors and exposure levels were associated with higher levels and persistence of distress? Well, in analysing our data, we've allowed for effects of age, sex, education, employment, risky drinking, smoking, and occupational exposures. However, psychological distress was still independently related to PM2.5. The schools data, which I'm not really going to talk about today, were adjusted for age, sex, and type of school. What key pollutants relevant to the scope of this study, based on extensive air monitoring data, were available? Our Environment Protection Authority very quickly provided us with data for particles, carbon monoxide, oxides of nitrogen, ozone, and sulfur dioxide. And it was really only carbon monoxide and PM2.5 and PM10 that exceeded our national environment protection measures. We also had some carboxyhemoglobin measurements, but unfortunately only limited ground level measurements were available at the outbreak of the fire, which is why we've had to rely on the modelling. How do we assess exposure? We developed a cumulative PM2.5 metric based on the model concentrations and time location diaries. There were also high spatial resolution estimates of carbon monoxide, but these were highly collinear, so we weren't able to separately identify an effect of carbon monoxide. And the early life follow-up stream, which I'm not really going to talk about much today, also developed similar average and peak PM2.5 metrics. What comparator populations might be suitable? For the adult survey, we chose the town of Sale, and I'll show you where that is in a little while. There was a slight complication, and we later had these mega bushfires in the so-called Black Summer of 2019-20, and Sale got slightly more exposure than Morwell. For the early life follow-up, they tested children conceived after the fire. And the school study looked at schools outside Morwell. The analyses of cancer incidence and survival, which I'm also really not going to say much about, made a comparison with the rest of regional Victoria. other important questions related to child development, the impact on older people, and the impact on community well-being. And the Early Life Follow-up has published their findings in relation to perinatal outcomes, symptoms, use of general practitioners and medication, vascular functions and lung mechanics. A report on older persons and relevant policies was accepted by the department quite early in the study. However, we did find a loss of trust in authorities and problems with official communication, and I suspect these are very similar to disasters elsewhere in the world. Had you told me 11 years ago that one of the outputs of this study would be a photography exhibition, I wouldn't have believed you, but there it is. We developed an exhibition on the future of Morwell, which toured quite widely and has now been archived. Coming back to a couple of the other earlier questions, is there evidence that people and susceptible subpopulations who are exposed develop over time clinical or subclinical cardiovascular or respiratory conditions? And this is why you need to do a cohort study. We found an increase in cardiovascular deaths, but not other major adverse cardiovascular events. And I'm going to tell you more about the results of our respiratory follow-up shortly. Is there evidence that people in general and susceptible subpopulations who are exposed have persistent psychological distress? The school study actually found that the stress in the children decreased from the 2nd to the 4th year, and I'll tell you more about our follow-up by the adult psychological impact stream. Well, what haven't we been able to do? We don't have a final answer to this question. Is there evidence people exposed to emissions compared with otherwise similar people not exposed have a higher incidence of malignant disease? And you would appreciate this was of considerable concern to the community. We have identified linkages with the cancer registry in Victoria and found a slightly higher incidence of all cancers up to 5 years after the fire, but not related to PM2.5 exposure. So we think that's probably confounded by some other difference. We have repeated anonymous cancer data extractions, and there were some rather strange effects there, which I can comment on if people are interested. And we've also done more identified linkages with the cancer registry in year 9. But both the government of the day and the official judicial inquiry said the study would run for 20 years. So the anonymous cancer extraction and identified registry linkages need to be repeated in some years' time, but that hasn't been funded. Watch this space. I'm now going to move on to some of the respiratory effects. So this particular analysis was led by one of our statisticians, Kath Smith. Most respiratory symptoms resolve 9 years after PM2.5 exposure from the mine fire. So, as you know by now, the study was established in response to community concerns. It is a multi-stream 10-year program of research. We conducted a baseline adult cohort in 2016-17. That was as soon as we could get into the field. And again, in questions, I'm happy to explain why it took that long. To be eligible to participate, adults had to be over the age of 18, listed on the electoral roll. Electoral registration's compulsory in Australia, and residing in Morwell, which was the most exposed town, or selected parts of Sale, which was not exposed because the modelling showed that the smoke didn't get that far. And in the end, we had just over 3,000 participants from Morwell and almost 1,000 from Sale. And this cohort formed the basis of our follow-up. The respiratory stream conducted further investigation of lung function and respiratory symptoms. So we have a random weighted sample from the adult cohort. We oversampled people with asthma, and we wound up with over 500 participants in this stream, 346 from Morwell, 173 from Sale, and conducted 3 rounds of follow-up. Now, just to summarise some of our previous findings, 2.5 years after the fire, there was an increase in self-reported respiratory symptoms, particularly cough, phlegm, and wheeze, associated with PM2.5. 3.5 years after the fire, people reported increased chest tightness and chronic cough, and we demonstrated increased reactance, i.e. stiffer lungs, on forced oscillation. Among the non-smokers, there were increased features of COPD. Among the smokers, more chronic cough. 3.5 years after the fire, there was poorer asthma control. During that 3.5 year period, there was a 21% increase in ambulance attendances for respiratory conditions. During the first 5 years after the fire, there was a 10% increase in emergency department visits for respiratory conditions and a 9% increase among women in respiratory hospitalisations. 7.5 to 9 years after the fire, the poorer lung function was no longer evident, and I'm going to show you those data shortly. So the question for this particular analysis was, does coal mine fire-related PM2.5 affect the long-term symptom trajectory? So just to remind you, we had the fire in 2014. We then got to do our baseline survey in 2016-17. So we called that wave 1 for this analysis. We then did the clinical testing in 2017-18, which I've called wave 2. And then a little thing called the COVID pandemic got in the way. And as those of you who might have been conducting field work at the time will know, it was more than an inconvenience. It made it very difficult to do any clinical research involving face-to-face testing. But eventually we got back in the field in 2021. And then the final wave was in 2023. So the outcomes here are self-reported symptoms such as wheeze, chest tightness, dyspnea, and nasal symptoms, chronic cough and chronic phlegm. The exposure is individual level, fire-related PM2.5. And the analysis has fitted mixed effects logistic regression models, looking particularly for a survey round or wave PM2.5 interaction, adjusting for the listed confounders. So these plots show the pattern of associations with PM2.5. This is the odds ratio for individual symptoms, and you can see that there is an association, particularly for wheeze in waves 1 and 4, an association with chest tightness in wave 3, no convincing effect on dyspnea. There may be a slight increase in the first wave and a slight increase in chronic cough in wave 2. The results were different for those who had asthma, and you might recall we oversampled for asthma compared to those who didn't have asthma, and in particular, the persistent wheeze was largely confined to the participants with a history of asthma. So in association with increasing PM2.5 exposure, wheeze was increased in all waves significantly in the first and final. Chest tightness increased in waves 2 and 3 before attenuating back to null. Shortness of breath was only increased initially. Chronic cough increased in wave 2 and then attenuated. There were no effects on chronic phlegm or nasal symptoms. So in conclusion, most respiratory symptoms associated with exposure to PM2.5 from the mine fire have since resolved. The exception is wheeze, with evidence of the effects of exposure persisting up to 9 years, particularly in those with pre-mine fire asthma. I'm now going to switch gears and talk about the findings for lung function. And this particular sub-study was led by one of our respiratory scientists, Tom McCrabb. I'm not sure how many of you might have visited Australia, but typically tourists don't go to the Latrobe Valley. It's an industrial area with coal mines and power stations. The red area here is the town of Morwell, which you can see over the period of the fire had an average PM 2.5 exposure of up to 20 micrograms per cubic metre. But the neighbouring areas of Moe, Traralgon, Churchill and Trafalgar were also fairly heavily exposed. Further afield, there wasn't much of an increase in PM 2.5. So the aim was to assess long-term impacts of the fire. This stream undertook clinical assessments. Here's the map that I promised you. Morwell is about 150 kilometres east of Melbourne, the capital city of Victoria, and Sale is a further 50 kilometres down the highway near the Gippsland Lakes. I've spoken about the questionnaires. This stream also included multiple measures of lung function, spirometry, gas transfer, oscillometry, and I'm going to focus particularly on multiple breath washout, which I appreciate as a test that maybe some of you are not that familiar with. And we also measured exhaled nitric oxide, but didn't find very much. So, as I've already said, there was an association between PM 2.5 and symptoms, findings on spirometry consistent with COPD and increased lung stiffness and worse asthma control. This is the schematic of the rationale for doing multi-breath washout. Some of you who've cared for patients with cystic fibrosis might be familiar with this lung clearance index, which is a global measure of the heterogeneity of ventilation or gas mixing. But it is possible to partition it into a portion derived from the conducting airways up to the 16th generation and an acinar component, which is from the 17th generation down into the alveoli. A rather busy slide, but this is a description of the participants who were tested. And you can see that we've got a reasonable spread of exposure. They were almost entirely Caucasian. The mean age was about 54 years. Quite a good gender balance. There was some imbalance for body mass index. The highly exposed Morwell participants were slightly more likely to be obese, but rather pleasingly, we had good participation by smokers. And as I've mentioned previously, we overweighted for self-reported asthma. Another busy slide, for which I apologise. We'll skip over the lung clearance index functional residual capacity. Somewhat surprisingly, we didn't find much of an effect on the acinar heterogeneity ventilation, but there was an effect on the conductive airways. And this shows the association between S-cond for every 10 microgram per cubic metre increase in PM 2.5. And you can see that this effect was present whether we fitted Morwell as an additional covariate to allow for residual confounding and whether we imputed missing data. So it was a fairly robust finding. I'll now move on to the apparent recovery of lung function following exposure. And this work was led by another of our respiratory scientists, Claire O'Sullivan. So the aim of this was to determine long-term impact on lung function of medium duration extreme exposure to PM 2.5. And the data here were derived from spirometry, gas transfer, and oscillometry. And the equipment may be familiar to many of you. These are the numbers. So we had 519 in the first round, but unfortunately there was a bit of an attrition, and by the third round there were only 244 still participating. Some maps which shows you the distribution of PM 2.5, and you can see that it changed dramatically with the direction of the wind. So we have a plume coming out of the mine and going west, and then on subsequent days blowing to the east. I've spoken about the exposure metric, and for this analysis, linear mixed effects regression models were fitted. And these are the results. Focusing first on spirometry, you can see that there was a reduction in forced vital capacity in the first round of testing, which subsequently disappeared. Conversely, however, the FEV1 to FVC ratio progressively decreased over time, and both of these time effects were statistically significant. We're looking here at the association of Z scores with 10 microgram per cubic metre increase in PM 2.5. These are the findings of the oscillometry, so that there is an effect on peripheral resistance, which resolves over time. Interestingly, the effect on lung stiffness is measured either by reactance or the area under the reactance curve was only present in the first round of testing. It subsequently appeared to have resolved. So just drawing all of these observations together, the increasing PM 2.5 exposure from coal mine fire smoke was associated with an increased heterogeneity of ventilation in the conductive region, suggesting conductive airways dysfunction. The resolution of the increased lung stiffness associated with this exposure was maintained, although a potential reduction in peripheral resistance took longer. During the follow-up, we observed no significant effects on gas transfer associated with PM 2.5. Extended follow-up revealed that vital capacity improved over time, and these findings overall are consistent with some recovery of lung function after exposure to coal mine fire smoke. Well, I'm going to shift gears again, and I'd like to talk a little about the psychological impacts, and this work was led by my colleague Matthew Carroll from the Monash School of Rural Health, based down in Gippsland. So the stream has been looking at the findings from various surveys that they've conducted, most recently a follow-up of mental health and well-being in 2022. They've published a number of papers on mine fire-related post-traumatic stress amongst Morwell adults 6 years after the fire, socio-demographic factors associated with different types of post-traumatic stress responses to the mine fire, relationships between physical health complaints, which are called somatic symptoms, psychological distress and trauma after disasters such as this mine fire, post-traumatic stress levels in response to the mine fire amongst school students 2 years after the event. And finally, and perhaps most interestingly, we've also had access to educational data, the so-called NAPLAN scores, the National Assessment of a Plan for Literacy and Numeracy, which is the bugbear of anybody with school-aged children or anyone working with a teacher, but it does provide system-wide data. And since I'm not going into any detail on that, I'll just foreshadow that the children in the Morwell schools were already scoring quite poorly on these measures, and they fell further behind over the period of the fire, and somewhat to my dismay, they have not caught up with students at other schools. And there's another paper looking at perspectives on community wellbeing, which has been very difficult to publish. We're up to our 8th journal now. Suggestions welcome. Okay, so these are the numbers of participants in the psychological impact stream. You can see that we've got a reasonable age range and we've got a good spread of exposure, over 524 participants in the most recent survey. The questionnaires have included measures of post-traumatic stress, the impact of the Vence scale revised, and more general psychological distress, Kessler's 10-item questionnaire, mental health diagnosis and socio-demographic indicators. And the stream have also been looking at some other things like the Black Summer, the COVID-19 pandemic, health-related quality of life. I'm not talking about those today, and also post-traumatic growth. So these are the scores on the impact of event scale revised and relationships with 10 microgram per cubic metre increments in PM 2.5. And you can see that the most heavily exposed people were the most distressed, and they remained distressed in the second round survey, but there was substantial improvement in the third round survey. And people took various trajectories. The majority of participants we considered to be resilient, and that is that they had not shown features of PTSD at any time point. And then we have this smaller group who have delayed onset of distress, either in the second or third round. And then there are those who appear to recover, and they either recovered by the second round or by the third round. And the clinical threshold here is a score of 24 or above. So you can see that there were some people who unfortunately were chronically stressed during all of our follow-ups. These are the results for the more general measure of psychological distress, not related specifically to the event, the Kessler 10-item questionnaire. And you can see that there is a relationship with exposure. The more heavily exposed people tended to be more distressed, but the group as a whole became progressively more distressed over time. So just to draw together the findings from psychological impact stream, the mindfire related post-traumatic stress had largely dissipated by the time of the third survey round, 8.5 years after the event. This was different from the second round, where levels of post-traumatic stress had increased, probably because of the Black Summer bushfires, which might have raised sensitivities in some participants. General level of psychological distress was steadily increasing in Morwell across the survey rounds, and this was associated with being younger, having physical symptoms, concerns about the COVID-19 pandemic, recent life stress, lower income, less social support and loneliness. But interestingly, there was no longer a relationship with exposure to mine fire smoke 8.5 years later. And encouragingly, there was some evidence of post-traumatic growth, such as greater appreciation of life and taking on new priorities, particularly among those who reported the most post-traumatic stress in the first survey round. Well, our experience, of course, is not unique, and there have been many devastating wildfires in North America, and most recently in the townships around Los Angeles. And maybe some of you have family members in that area or were involved in treating some of the patients. And I would speculate that maybe the mixture of air pollutants, which obviously included combustion of residential buildings and furnishings and motor vehicles and machinery, might be even more toxic than smoke from a coal mine fire. And I'd be very interested in your thoughts as to what needs to be done to investigate the health effects of those devastating wildfires. So I need to make a few acknowledgements for the pictures. I always have to say, whenever I talk about the Hazelwood Health Study, that although it was funded by the Victorian Department of Health, the views in this presentation are mine and those of my colleagues, not the department. I particularly want to thank all of the Hazelwood investigators, staff and students, especially our senior project manager, Jill Blackman, the respiratory scientists, some of whom I've named, the Latrobe Valley Health Assembly, the Gippsland Primary Health Network, and the Latrobe Health Advocate, whom we have dealt with in trying to disseminate and translate the findings, and ultimately the Latrobe Valley community. We could not have done the study without them calling for it in the first place and subsequently supporting us. That's a team photo, obviously pre-pandemic, but you don't do this sort of research by yourself, and we're able to put together a very talented, capable, multidisciplinary team. These are references to our publications and some of the other publications that I've cited during the presentation.